Good afternoon, everyone. Hello. It is my pleasure to welcome you today to Susan G. Komen's virtual Metastatic Breast Cancer Impact Series event. My name is Gina Chicatel, and I am a manager of mission education at Susan G. Komen. The programming for this series is envisioned as a year-long conversation with attendees, presenting new information and speakers each month. Today, our topic is treatment and research for HER2-low metastatic breast cancer. Our featured speaker is Dr. Aditya Bardia, and our fantastic moderator is Lexi Vudrag, MBC advocate. Before we begin, Komen would like to thank our sponsors for supporting the 2025 MBC Impact Series. Thank you to our premier sponsors, AstraZeneca, Gilead, and Merck, and our signature sponsor, Daiichi Sankyo. This series is made possible because of their generosity. One more housekeeping note, while our speakers are talking, please feel free to post your questions in the Q&A feature in Zoom, and we will get to as many as we can. Please remember, our speakers are not able to provide individual medical advice, so please keep questions as general as possible. Towards the end of our programming, a survey link will be placed in the chat. Your feedback through this survey is very important to us and helpful as we plan for future MBC programs, just like the one you're with us for today. So now we are excited you are all joining us for today's discussion. And to start, I would like to introduce you to our moderator, Lexi Vudrag. Lexi Vudrag lives in the suburbs of Phoenix, Arizona with her husband, Nick, and together they have two grown daughters, Christy and Carla. Lexi has 40 years of experience as a paralegal and director in real estate management and development. She and her husband are 20-year franchisees of Rocky Mountain Chocolate Factory. They own and operate the store located in Uptown Sedona, Arizona. Lexi is also a member of the Franchise Advisory Council for Rocky Mountain Chocolate Factory, Inc. Lexi was diagnosed with de novo metastatic breast cancer in 2022. Shortly after finishing chemotherapy, she experienced pathological fractures in her pelvis due to the cancer treatments weakening her bones. These fractures made it nearly impossible to walk without the use of walking aids. At the direction of her incredible medical team, she began a fitness regimen, incorporated changes to lifestyle, and worked hard on becoming physically fit. She managed to recover from the fractures and is now active and thriving. Lexi is passionate about helping the MBC community sort through the emotions, fear, and chaos that ensues when diagnosed with metastatic disease. She aims to inspire hope and help others find the key to unlocking their own best quality of life. In conjunction with the treatments and therapies available today and those on the horizon, Lexi believes that with great determination, it is possible to thrive with MBC. Could not agree with her more. Lexi, I'll turn it over to you.
Thank you, Gina. This is a very important topic to all of us. And since HER2-low is a relatively recent development, I'm very eager to hear Dr. Bardia's presentation. Dr. Bardia is an internationally renowned breast oncologist known for his pioneering clinical and translational research in the field of cancer therapeutics, particularly antibody drug conjugates. Dr. Bardia led the development of sactuzumab govitecan, the first ADC approved for patients with metastatic triple-negative breast cancer, as well as others, including trastuzumab deruxtecan and datopotamab deruxtecan. Dr. Bardia also led the clinical development of elacastrant, the first oral SERD approved for patients with metastatic HR-positive breast cancer. In translational collaboration with various labs, identified the role of ESR1 mutations in mediating endocrine resistance, RB1 mutations in mediating CDK4/6I resistance, and TOP1 mutations in mediating ADC resistance. Besides cutting-edge research, Dr. Bardia is highly regarded among peers as an excellent mentor and strong advocate for academic trainees and junior facility members. Dr. Bardia has received several awards, including Outstanding Award for Research Excellence at Mayo Clinic, the Young Investigator Award from ASCO, Distinguished Researcher Award from MASCO, and Douglas Family Foundation Prize for Excellence in Oncology Research. And so without further delay, I'd like to introduce Dr. Bardia.
Excellent. Thank you so much, Lexi. Thanks for sharing your story as well. Our focus today would be talking about metastatic breast cancer, about the various advances we've made over the years and how we continue to advance the field. So I'll focus predominantly on antibody drug conjugates and HER2-low breast cancer. This is a webinar. Please send in your questions as I'm presenting throughout the presentation. Please feel free to send in questions. I'll present for about half an hour or so, and then we'll also have time for questions at the end. Again, this is meant to address questions that you might have, so please feel to send in your questions. So let me switch. Alexa, we can see the slides.
Yes, slides are good.
Great. So I'll essentially review the advances we've made in hormone receptor positive, HER2 negative, essentially HER2 low breast cancer with a spotlight on antibody drug conjugates. These are my disclosures. I'm very involved with clinical trials and the institution gets grants related to the clinical trials. So I'm a medical oncologist. I see patients with breast cancer. As a medical oncologist, felt it would be good to start with the common scenario we see in clinic. This is a 55-year-old postmenopausal female with hormone receptor positive breast cancer. She was told that she has HER2 negative disease, couple of biopsies in the past, one the metastatic biopsy and one the primary breast cancer biopsy. Both had shown a HER2 IHC of 0. For hormone receptor positive breast cancer, we generally use hormonal based therapy. So that's what we started with. And then after that, she received capecitabine oral chemotherapy agent. Doing well. She has a history of inflammatory bowel disease, but otherwise doing well. So the question in the clinic is, what would be considered next for this patient? We have eribulin, navalbine. These are chemotherapy agents. We have a few antibody drug conjugates as well, sacituzumab govitecan, trastuzumab deruxtecan, datopotamab deruxtecan. So the question is what to consider next in this patient's journey. An important point to note is that more information is needed. We cannot make a decision at this time till we have more information. And the specific information we need is more clarification of the HER2 IHC 0 or the so-called HER2 negative, because negative might not be negative from a HER2 expression perspective, and we'll review that. This becomes important because of antibody drug conjugates. So this is a schema that describes how antibody drug conjugates work. So if you look at number 1, so that's the antibody drug conjugate or the ADC. It's there. It essentially has an antibody with generally chemo or payload attached to it. So that's the orange payload, and the antibody is depicted, and the payload is attached to the antibody. The antibody, when it's infused, binds to a cancer cell that expresses the antigen. So the role of the antibody is to bind to an antigen that's overexpressed. And that is how it provides selectivity. So it's essentially like a Trojan horse. It's sending in the payload or the chemotherapy preferentially to cancer cells. And then once it binds, then it gets inside the cancer cell. That's number 2, so internalization. Then number 3, it's degraded. Number 4, the payload is released. And number 5, it causes death of the cancer cell. So essentially, it's a way of giving high doses of payload selectively to cancer cells. You want to kill the cancer cells without impacting the normal cells. That's the intent. And newer drugs also have a bystander effect. Once the cancer cells die or the payload is released in the cancer cell, it's membrane permeable. It can go in the tumor microenvironment as well. So it can impact cells that have lower expression of the antigen. And this becomes important as we talk about HER2 low. I'll spend a few minutes because I think this is a very important slide and would provide clarification as to what is HER2 low, what is HER2 ultra low, what is HER2 positive. So if we look at the history of HER2 positive breast cancer, HER2 positive breast cancer was defined based on a test called immunohistochemistry or IHC. So IHC looks at the expression of an antigen. HER2 positive was defined as tumors that have high expression of HER2. So HER2 IHC 3 plus was defined as HER2 positive. And everything else was considered HER2 negative, but negative is not negative. There's still HER2 expression in the so-called HER2 negative tumors. So let's look at what is HER2 IHC 2 plus and 1 plus. As I mentioned, 3 plus is positive, but what about 2 plus and 1 plus? So 2 plus refers to weak to moderate complete membrane staining in more than 10% of cells. And 1 plus is incomplete membrane staining in more than 10% of cells. So even 2 plus and 1 plus, there is membrane expression of HER2. And for antibody drug conjugates, you just want the antigen to be there. It'll then latch onto it and then release the payload. So antibody drug conjugates that target HER2 would potentially work in HER2 IHC 2 plus and 1 plus. How about 0? But again, 0 is not 0. Even tumors that are IHC 0, they can be faint or membrane staining, but in less than 10% of tumor cells. And these newer ADCs that bind to HER2, even if it binds to a few tumor cells, because of the bystander effect, it can impact the other cells that do not have expression of HER2. So this has been a game changer for the field because it has expanded the use of effective drugs for a broader patient population. So I would again emphasize HER2 negative might not be negative from a HER2 expression perspective. It's important to further classify that as either HER2 low or HER2 ultra low, because that refers to the expression of HER2 in the tumor cells. It's an operational definition. It's not a biological definition. I'm not making the case that HER2 low biologically is different from, say, HER2 ultra low or HER2 IHC 00. It's not a biological definition. It's an operational definition that can help us identify a subset of tumors that have HER2 expression so that we can use appropriate therapies. So it's more for patient selection, more for selection of therapies targeted against the tumor. And a prime example of this is T-DXd or trastuzumab deruxtecan. Trastuzumab deruxtecan has trastuzumab or Herceptin as the antibody, but it's attached to a payload deruxtecan. And the idea is Herceptin would bind to a HER2 cell, release the payload, causing apoptosis or cell death. So this was first evaluated in the DESTINY-Breast04 study. This was a very important study. It was presented at our major meeting, ASCO, in 2022. It was featured in the plenary session, received a standing ovation as well, because essentially it was a game changer for the field of breast oncology and other cancers as well. This trial included patients with the so-called HER2 low breast cancer. So if you remember, HER2 low essentially refers to tumors that have HER2 IHC expression of 1 plus or 2 plus. Technically, it's HER2 negative as per the previous definition, but negative is not negative. There can be some HER2 expression. And so those patients with the so-called HER2 negative breast cancer were included in this trial. And it showed a significant improvement in progression-free survival and overall survival for patients who received T-DXd versus standard of care chemotherapy. So this is a Kaplan-Meier curve. You might have seen this in the past. On the y-axis is progression-free survival, meaning that there is no disease progression, and on the x-axis is time. So when the trial starts, 100% of the patients are alive without disease progression for that study. So it starts at 100%. And then over time, some patients have disease progression. And so that causes a drop in the curve and so on and so forth. So over time, you see separation in the curves if one drug is better than the other because it takes a longer time to have disease progression if the drug is more effective. And so TDXT, as you can see, which is depicted in blue, delayed disease progression as compared to the control arm. You can see a clear separation in the curve, and this was seen across all defined subgroups. This was for HER2 low. How about HER2 ultra low? As I mentioned previously, even HER2 ultra low refers to tumors that have some expression of HER2. Previously, it was classified at IHC 0, but 0 might not be 0. There could be some expression of HER2 in less than 10% of cells, and that is sufficient for an ADC to bind, release the payload, and with the bystander effect, have an impact. So this concept was proven in the DESTINY-Breast06 study, where HER2 ultra low was also included besides HER2 low. And in this clinical trial, again, there was improvement in progression-free survival with TDXT, a median progression-free survival of 13.2 months. It's median, versus about 8 months with standard chemotherapy, and you see a separation in the curve in favor of TDXT. The team then also looked at HER2 ultra low versus HER2 low in terms of the response rate. So this is a waterfall plot. In a waterfall plot, the y-axis essentially refers to the change in the tumor volume. With increase in disease, the tumor volume would increase. With decrease in disease or tumor reduction, you would see a decrease in tumor volume. So anything that goes down is good because that would suggest tumor reduction. Anything that goes up is bad because that would suggest that the tumor is increasing. So with TDXD, the response rate, which is defined as 30% or more reduction in the tumor, was 56% versus 30% with standard chemo. And again, with HER2 ultra low, TDXD had a response rate of 60% versus about 25% with standard chemo. So clearly more effective than standard chemo, and the study proved the point that even in HER2 ultra low, even if there is some expression of HER2, that is sufficient for these agents to bind, release the payload, which can then cause apoptosis and cell death. Now, what about the side effects? Whenever we talk about the drug, we talk both about efficacy as well as the side effects. The common side effects seen with TDXT include nausea. That's the #1 side effect we see with TDXT. And the way to manage that is to use anti-nausea medications before infusion. In general, we also consider olanzapine as a breakthrough medication for nausea, despite the anti-nausea medications given during infusion. Other side effects to be aware of include alopecia, some drop in the counts. But one very serious side effect to be aware of with TDXT is lung inflammation or pneumonitis. There have been deaths because of pneumonitis with TDXT in clinical trials. So that's a very important side effect to note related to TDXT. If a patient is having any symptom, any cough, any shortness of breath, that is something important to consider when we are using TDXT, because that could be a sign of pneumonitis. So how do we manage that? The key is early recognition and management. Steroids are the mainstay in a patient who is symptomatic. We give steroids, and with steroids, usually you can manage the pneumonitis and also discontinue TDXT. Even if a patient is asymptomatic, so you're just seeing pneumonitis on scans, but the patient is not having symptoms, even for asymptomatic pneumonitis, the recommendation is to hold TDXT and consider steroids to allow this to recover, because we don't want the pneumonitis to increase. It's such a serious side effect. The key is early recognition and management. The incidence is about 10% or so based on the clinical trials. So it is a side effect that could be seen, and important to know about this side effect with TDXT. Okay, so we talked about TDXT, we talked about HER2 low, we talked about how that works. I'll briefly also touch on the 2 other antibody drug conjugates that are FDA approved. The other drug to consider is sacituzumab govitecan. It's also an antibody drug conjugate, so you have the antibody and then the payload is attached to the antibody. This drug targets TROP2, which is also overexpressed in breast cancers, triple-negative breast cancer, hormone receptor-positive breast cancer. This was evaluated in the pivotal ASCENT study for patients with triple-negative breast cancer, where it was compared head-to-head against standard chemotherapy. And to cut a long story short, it showed an improvement in progression-free survival and overall survival. Again, you see the separation in the curves. We look at the Kaplan-Meier curves early on in favor of sacituzumab govitecan as compared to standard chemo. If we just look at the medians, there was close to tripling of progression-free survival and doubling of overall survival. So medication that improved overall survival for patients with metastatic triple-negative breast cancer. And so this was FDA approved during the pandemic in April of 2021. But the drug also works in hormone receptor positive breast cancer. Because if we look at the expression of TROP2, it is not that different between hormone receptor positive breast cancer and triple negative breast cancer. The drug was first evaluated in triple negative breast cancer because of the unmet need and other reasons, but the drug potentially would work in hormone receptor positive breast cancer as well. And so this was evaluated in a study, the TROPiCS-02 trial. And again, you can see a separation in favor of sacituzumab govitecan versus standard chemotherapy. And there was improvement both in progression-free survival as well as improvement in overall survival. So this is the second drug that's FDA approved for patients with hormone receptor positive breast cancer. And this includes HER2 low breast cancer as well. So HER2 low breast cancer has HER2 expression, also has TROP2 expression, and this drug works in that setting as well. What are the side effects with this drug? The drug has three major side effects. The first one is neutropenia. It results in a major drop in the white blood cells. Those are the cells that fight infection. So often the physician would consider medications to boost the white blood cells. The second side effect is diarrhea. This medication can result even in severe diarrhea. So it's important to consider antidiarrheal medications like loperamide to control the diarrhea that can come from use of sacituzumab govitecan. Nausea can also be seen with sacituzumab govitecan, and very similar to T-DXd, generally recommend anti-nausea medications, and for breakthrough nausea, olanzapine. The drug also uniformly causes alopecia, so it's important to counsel whether cold caps are effective or not. We don't know, but certainly something to be aware of in the use of SG or sacituzumab govitecan, which is hair loss. Side effects that are not seen with sacituzumab govitecan include neuropathy. Some patients have baseline neuropathy from prior use of paclitaxel, taxanes, or platinums, but this is a drug that can be used in that setting because it does not worsen neuropathy. It also does not have an impact on the heart, so it does not cause any heart toxicity. And so far, we've not seen any evidence of pneumonitis or the lung inflammation. So if there's a patient who's received, say, T-DXd and then has lung inflammation, pneumonitis, and you have to discontinue T-DXd, SG is a potential option to consider because the drug does not have that side effect. How about impact on quality of life? Briefly, for majority of the domains in the pivotal study, you could see that the time to deterioration in quality of life was longer with the use of SG in most of the domains, except diarrhea, because that's the side effect. But other than that, in general, it maintained quality of life, and patients were able to maintain the quality of life for a longer period of time with sacituzumab govitecan as compared to standard chemo. That's an important point because whenever we use a drug in metastatic breast cancer, our goal is twofold: to improve survival and also to maintain improved quality of life. The third drug that's approved in this setting is datopotamab deruxtecan. It's kind of a mix between T-DXd and sacituzumab govitecan in the sense that it targets TROP2. So unlike T-DXd, which targets HER2, this one targets TROP2, but the payload is the same, deruxtecan. In T-DXd and Dato-DXd, both have same payload, which is deruxtecan. So this was evaluated in a pivotal clinical trial, TROPION-Breast01, comparing Dato-DXd to investigator choice of chemotherapy. And similar to the other studies, also showed an improvement in progression-free survival. You could see a separation in the curves early on, Dato-DXd represented in brown, and this was maintained over time as well. So this drug is another agent that's shown improvement in progression-free survival for patients with metastatic hormone receptor positive breast cancer. How about overall survival? That's where things get a bit tricky with this drug. Uh, Overall, the drug did not show an improvement in overall survival. However, there was an imbalance in the use of subsequent ADC therapy after patient had disease progression on Dato-DXd. And if you control for that balance, then you see an improvement in overall survival, trend towards improvement in overall survival with Dato-DXd as compared to standard chemo. So it just talks about the complexity in interpreting overall survival results when we have multiple agents, but very important to look at it because it's an important endpoint, probably the most important endpoint from a patient and field perspective, which is overall survival. In terms of quality of life, the time to deterioration in quality of life was longer with Dato-DXd in most of the domains, the emotional, social fatigue. This was presented at our ASCO meeting last year. So it did delay deterioration in quality of life as compared to standard chemotherapy. In terms of side effects, interestingly in this trial, the overall incidence of side effects were lower with Dato-DXd as compared to chemo. With most of our studies, generally we see that the intervention arm has more side effects than the control arm, but here it was the opposite. The incidence of side effects were lower with Dato-DXd as compared to standard chemo. So if we look at, say, incidence of grade 3 or higher toxicity, that was 21% with Dato-DXd versus 45% with standard chemo. So about half the rate of side effect or severe side effects with Dato-DXd as compared to standard chemo. And we can objectively look at this. If we look at specific side effects like neutropenia, that was much, much lower with Dato-DXd. So the drop in counts was much lower with Dato-DXd as compared to standard chemotherapy. The main side effect that is seen with Dato-DXd is stomatitis or mouth sores. So let's talk a bit about mouth sores. So that is the main side effect seen with Dato-DXd, usually occurs in the first month. We recommend the use of a steroid mouthwash 3 to 4 times a day, both when you're starting treatment, so primary prophylaxis, as well as if mouth sores occur, then you can increase the frequency, you can add other things as well. The other thing to consider is the use of ice chips or ice water during infusion. It is something that's been used with other therapies as well, and there's some evidence that that can reduce mouth sores that come with Dato-DXd. So that's an important side effect to note with Dato-DXd, and the key is the use of steroid mouthwash as well as ice chips during infusion. So the drug was recently approved on the 17th of January 2025. The FDA approved datopotamab deruxtecan for patients with metastatic hormone receptor positive breast cancer who had received 1 prior line of chemo. The approval was for HER2 negative breast cancer, and again, negative includes HER2 low. So if a patient has HER2 low disease or HER2 ultra low disease, all of that is included in this current label of HER2 negative breast cancer. Maybe in the future, we need to rethink our labels, but at this time, that's the definition that's used. So this drug is approved for HER2 low and ultra low breast cancer as well. How about other ADCs? One other ADC to consider is HER3-DXd or patritumab deruxtecan. It targets HER3, which is another antigen, and works across ER-positive, triple-negative, and HER2-positive breast cancer. This drug is not approved yet. There are ongoing pivotal phase 2, phase 3 clinical trials, but it is an agent to look out for. And besides this, there are a number of other drugs in development. So I'll finish with talking about with these different ADCs in the future, how are we going to sequence the different ADCs? And I think the key is understanding mechanisms of resistance. So let me give you an example from a work we had done previously. This was a patient with metastatic triple-negative breast cancer who received sacituzumab govitecan, did very well on sacituzumab govitecan. After about 2.5 years, somewhere in that range, had disease progression and unfortunately expired. Doing whole exome sequencing of the different lesions, identified that there were mutations in both TROP2 and TOP1 that cause resistance to sacituzumab govitecan. Why is this important? So let's look at the schema. Under wild-type conditions, sacituzumab govitecan binds to TROP2, gets inside the cancer cell, releases SN38, which then causes cell death. But if there's a mutation in TOP1, you have the first few steps, the drug binds to the target, gets inside the cancer cell, releases the payload, but the payload does not work because the site at which SN38 binds, that undergoes a mutation. So the payload doesn't work, and this has implications for sequencing because if you use a TOP1 payload sequentially, that's going to cause resistance. Trastuzumab deruxtecan, sacituzumab govitecan, datopotamab deruxtecan, all the three ADCs that are FDA approved have a TOP1 payload. So in the presence of TOP1 mutation, there could be cross resistance when these drugs are used sequentially. On the other hand, if the resistance is more towards TROP2, that's the antigen, then the drug does not bind to its target, but then you could sequence with another drug that binds to a different target. So for example, if there's TROP2 mutation, after that you can use TDXT. TDXT does not bind to TROP2, it binds to HER2. So there's no cross resistance. So just understanding whether the resistance is more towards the payload or the antigen can help with sequencing of ADCs. So this is my summary in terms of general guideline for management of hormone receptor positive breast cancer. In the first line setting, we use hormonal therapy plus a CDK4/6 inhibitor. After disease progression on that, it gets complicated. We usually do genotyping, and then based on the mutations, we use therapies like for ESR1 mutation, elacestrant, PI3 kinase mutation, and PI3 kinase inhibitor, and so on and so forth. So usually we use 2 or 3 lines of hormonal-based therapies. And then after that, when we are transitioning to more of an endocrine resistant setting, that's where ADCs can play a role. You have TDXT for HER2 low and HER2 ultra low breast cancer, also sacituzumab govitecan, and now datopotamab deruxtecan. So there are multiple options to consider in this setting. And then you have chemotherapy, eribulin, navalbine, gemcitabine, capecitabine. So a number of options to consider in this endocrine resistant setting as well. So ADCs have truly revolutionized the care of hormone receptor positive breast cancer. There are multiple ADCs now available, datopotamab deruxtecan, sacituzumab govitecan. There are others in development like sacituzumab tirumotecan. And these drugs will likely further change how we treat not only metastatic breast cancer, these are also being evaluated in early breast cancer and hopefully can prevent metastatic disease. So a lot of excitement related to these ADCs. While they're effective, we need to manage the side effects well also, because it's about both improving the overall survival as well as improving the quality of life for patients with cancer. Thanks so much for your attention. I'll stop and open it up for questions.
Thank you so much, Dr. Bardia. The first question we have is actually a two-parter. The question is, can a HER2-low therapy be combined to another therapy when there is heterogeneous disease? And if one HER2-low medication fails, does it mean all the others will fail?
Yeah, a good question. So that's a very insightful question in terms of HER2 heterogeneity. The previous ADCs that did not have a bystander effect, like TDM1, were not that effective for HER2 low disease. But the newer ADCs, because of the bystander effect, even if there is HER2 heterogeneity, so let's say there are 10 cancer cells and 7 of them have HER2 expression and 3 don't, the ADC would bind to those cells that have HER2 expression, release the payload, and because of the bystander effect, will even impact cells that have low or zero expression of HER2. So these newer ADCs with bystander effect have essentially address the heterogeneity issue. Doesn't mean we cannot do better, absolutely. So there is interest in combination therapy, also TDXT combined with other drugs, including targeted therapies. The second question was about if HER2 ADC is ineffective, does that mean the other HER2 ADC would be ineffective? Not necessarily. So for patients who have disease progression on TDXT, if the resistance is more towards the payload, then using another HER2 ADC with a different payload potentially would have efficacy. And there are ongoing trials with other HER2 ADCs that have different payloads. So absolutely, failure of one drug does not mean it's a class failure. Other drugs potentially could work in that setting.
Thank you. The next question is, I am ER/PR positive, HER2 low. I have been on CDK4/6 inhibitors, currently Faslodex and Verzenio. Recent findings punctuate brain lesions and had the gamma knife. What drugs cross the blood-brain barrier involving my subtype? Thank you.
That's a good question, and it is something that can be seen in hormone receptor positive breast cancer, certainly triple negative breast cancer as well. Verzenio does cross the blood-brain barrier, but certainly could have disease progression, including in the brain with Verzenio. Other drugs in this setting that cross the blood-brain barrier include elacestrant. If there is ESR1 mutation, that's a drug to consider. Ribociclib can cross the blood-brain barrier as well. These newer ADCs, including trastuzumab deruxtecan, can cross the blood-brain barrier. So a number of agents that could be considered in this setting.
And our next question is, can the sacituzumab govitecan or the Dato-DXd be used for HER2 low metastatic breast cancer patients that previously underwent T-DXd treatment and failed to respond to it?
The short answer is yes. And actually, I have a patient in clinic that I recently started this therapy after the patient had disease progression on T-DXd. So there's not complete cross-resistance between these ADCs. You can certainly use sacituzumab govitecan as well as datopotamab deruxtecan for patients with HER2-low disease who've received prior T-DXd.
Thank you. Is there an alternate dosing schedule for the sacituzumab instead of the 21-day cycle?
Good question. We had brought this up previously. At this time, the recommended schedule is day 1, day 8, every 21 days. But there are some patients who just have a lot of difficulty with the day 8 because of side effects. And sometimes we do consider the treatment every 2 weeks or just skip the day 8. That's not a schedule I would start with, but if you're having a lot of difficulty with day 8, potential options would be to just skip day 8 and do it every 3 weeks, like T-DXd or Dato-DXd, or switch to every 2 weeks. And in that setting, you can often use long-acting growth factor support as well, very similar to how we do dose-dense AC, where the drug is given every 2 weeks along with growth factor support.
Thank you. How long can a patient safely use topical steroid mouth medications before problems like candida develop?
Usually the mouth sores are in the first few cycles. After 6-8 cycles, you can decrease the use of mouthwash. We've used it with everolimus as well. Generally, have not seen problems with candida or thrush, but that is something to be aware of. And if the physician is seeing candida thrush, then that needs to be treated as well.
We have a participant asking, what if I have no mutations?
If there are no actionable mutations, there are still therapies that are available. The CDK4/6 inhibitors do not require the presence of actionable mutations. None of the antibody drug conjugates like T-DXd or sacituzumab govitecan or datopotamab deruxtecan require the presence of these actionable mutations. So there are other therapies one could consider.
Thank you. The next question is, how do you know if a tumor is HER2 low or ultra low?
The HER2 low, ultra low is an operational definition that's based on the degree of HER2 expression that can be detected by IHC or immunohistochemistry. If more than 10% of tumor cells have HER2 expression that is detectable by the IHC, that's HER2 low. If it's less than 10%, then that is HER2 ultra low. So if it's 5-6%, that would be considered HER2 ultra low. If it's 30-40%, that would be considered low. So it's based on the degree or the number of cells that have HER2 expression that defines HER2 low versus ultra low.
How quickly should someone see results with ADCs? Are tumor markers a reliable guide to efficacy?
The ADCs, similar to chemotherapy, work quickly. So usually when you get your first staging scan, you could see either tumor reduction or at least stability with these ADCs, as opposed to hormonal therapy alone, where sometimes it can take a while. Usually with ADCs, we do see the response early on. And tumor markers do work. I would not trust the tumor marker just after the first cycle, because sometimes with cell death, the tumor markers can go up. So say you've started T-DXd and then you get tumor markers on cycle 2, day 1, and they are up. That does not necessarily mean disease progression. It could be cell death. But then it should come down by cycle 3, day 1. So it can initially go up, but then eventually it should come down. If from the start you're seeing them come down, that's definitely a good sign.
Thank you. Do you think patients hear the term HER2 low from their oncologists now?
I think it's gaining traction, both HER2 low as well as HER2 low breast cancer. And if it's not this, if the provider does not mention it, I think it's very reasonable for the patients to ask, do I have HER2 low or HER2 low breast cancer? Just looking at the term HER2 negative again does not mean it's not low or ultra low. So if for any patient who has HER2 negative disease, it's very reasonable to ask the provider whether I have HER2 low or HER2 ultra low disease. It might not change the management right at that time, but is helpful information that will have an impact in the future.
Thank you. In terms of METs, are there any data on which ADC is better for one organ MET than the other?
You don't have data yet, so if there's disease in the lung versus liver versus the bone, would one drug be better than the other? We've not seen any data yet, but over time, as we have trials comparing these ADCs, then we should be able to see if a drug works better for a certain cancer in a certain setting versus not.
Thank you. For patients that are metastatic triple negative and have clear scans, good labs, and tumor markers for 1 year, is it feasible to stop the sacituzumab?
Yeah, it's something we struggle with these drugs. So a patient with metastatic disease has a complete response. You don't see anything on the scans, and the tumor markers say are normal as well. Even do a circulating tumor DNA and there's nothing detectable. Do you stop the drug? Certainly could consider a treatment holiday and then monitor things closely. At what point should we stop the drug completely? We just don't know. We struggle with this with trastuzumab as well. Patients can be on trastuzumab for 5-10 years, and then do we stop the drug at that time? We just don't know. But I think it's certainly reasonable to consider a treatment holiday and monitor closely.
Okay, thank you. Are there any clinical trials available for those with HER2 low or ultra low?
Yes, so trials that are for HER2 negative breast cancer would also be applicable for HER2 low as well as ultra low disease. Newer HER2 ADCs that are targeting this subgroup, that would also be something to consider. So absolutely, there are newer drugs being developed for this category, drugs that could work potentially after T-DXd or even instead of T-DXd and have a different side effect profile, such as don't cause pneumonitis. I think that would be helpful for the field.
Thank you. Are there any new discoveries or options coming for those with HER2 low beyond trastuzumab deruxtecan?
The innovation is happening on two fronts. The first is newer drugs and better drugs with lower side effects. And the second is the ability to measure HER2. Right now, we're just using immunohistochemistry, which is great for identifying high expression. It's not good for identifying low expression. So we need more quantitative assays, and those are being worked on.
Thank you for that. If progression after CDK treatment for years, what is the test a patient should get to look at for HER2 low? Or do doctors go with original biopsy results?
We can go with the original biopsy results. So the primary breast cancer or the metastatic breast cancer specimen that can be used to look at HER2 low and the pivotal clinical trials that was allowed. But if consistently all the prior biopsies show that the tumor is HER2 completely zero, there's no membrane staining, so it's not even ultra low, then you could consider a new biopsy, but that's pretty rare now with ultra low. Usually majority of patients would either have HER2 low or ultra low disease.
Thank you. As a follow-up to the comment about the clinical trials, how can patients learn about possible trials?
I think it's best to ask your provider about potential clinical trials that are available. Webinars like these are very helpful because we review potential treatment options. Clinicaltrials.gov is another website. It can be a bit clunky trying to identify clinical trials on that website, especially if it's in a specific setting. So webinars, discussion with providers, peer support, I think those would be other avenues.
Should there be a time lapse between ADCs?
Yeah, it is something that's been looked at, and there was some data presented last year. So the question refers to if a patient is on T-DXd, and then after disease progression on T-DXd, should I use, say, datopotamab deruxtecan, or should I bring in another chemotherapy like eribulin and then use datopotamab deruxtecan? The data that was presented showed that there's no difference in either of the approaches. There are some physicians who like to bring in chemos just to space things out. There are others who are like, what if the patient doesn't get to the next line? I want to use my most effective agents early on. Personally, I'm more of the second camp. I like to use the effective agents early on. But if I use an ADC after ADC, with the second ADC, I usually get scans after 2 cycles. I don't wait for 4 cycles because if the treatment is not working, I want to know that early on so I can make a switch.
Thank you. How common are HER2 low breast cancer now?
With 60 to 70% of HER2 negative breast cancers would be HER2 low. And I would say 20-25% would be HER2 ultra low. So 90% plus of HER2 negative breast cancers would either be HER2 low or HER2 ultra low.
Thank you. I think that this question, you may have already addressed this, but how would you explain HER2 low to a patient?
The key is HER2 low essentially refers to low expression of HER2 on the cancer cell. So it means that there is some HER2 expression on the cancer cell, and there's a specific therapy that can target.
And does RB1 loss affect the use of ADCs like it does with CDK4/6s?
Yeah, that's an insightful question. With RB loss, we do see resistance to CDK4/6 inhibitors, but we've not seen that with ADCs. With ADCs, it's more the payload, like TOP1 mutations, that can cause resistance.
Thank you. Sorry. If ribociclib was used as first line, then moved to T-DXd, can the patient move back to the other ER therapies afterwards if they do not have any confirmed mutations? Or is it better to move to stronger chemotherapies?
Ultimately, it's a patient-centered discussion, but it's very reasonable to move back to hormonal-based therapies. So after T-DXd, you could consider endocrine therapy plus a different CDK4/6 inhibitor like abemaciclib, or you could consider everolimus. So it's very reasonable to reconsider hormonal-based combination therapy after T-DXd.
And we have someone here asking, why, if one person is stage 4, only receive palliative treatment?
I think our goal for treatment in the stage 4 setting is improvement in overall survival and improvement in quality of life. So I think the goal is twofold. In terms of cure, we don't have the magic bullet yet, but that's where research is ongoing. There's a study being conducted with combination therapy to potentially even cure metastatic HER2-positive breast cancer. And other cancers also, I think we will see combination therapy. So as we have effective agents, we would potentially revisit the possibility of curing metastatic breast cancers.
Thank you. If a patient tumor markers are unreliable, is there any other test line, Signatera, or any circulating tumor cell tests used for MBC?
Certainly could be considered. I sometimes do use circulating tumor DNA, often in triple-negative breast cancer where the tumor markers can be normal. So the circulating tumor DNA test, like a tumor marker, can tell us about the disease burden and can be something that you can track.
Thank you very much. At this time, I'm going to turn it back to Gina.
Maybe if my computer will let me turn my audio and my video back on. But want to thank both Lexi and Dr. Bardia for lending their time, their talent, and their expertise on this topic. We had a very engaged audience asking a whole bunch of great questions. So I want to thank our audience for also being with us today. As a reminder, today's session was recorded and will be posted on our landing page soon. So you can rewatch this session or view any of our previous content that we've posted that you may have missed. So please help us spread the word about this important content with your friends, your family, your healthcare professionals, anyone in your networks that you think would benefit from the information. And you can always visit our landing page to sign up for events like this or our monthly metastatic breast cancer focused newsletter to stay informed. And you can go to komen.org/MBC series for that. Let me see how tech savvy I can be to drop that link in the chat while I am talking. So there's the link to the metastatic breast cancer landing page. And before we go, I want to thank our sponsors once again. So we have our premier sponsors. Get that out of the way, maybe. We have our premier sponsors, AstraZeneca, Merck, Gilead, and our signature sponsor, Daiichi Sankyo. Again, this series is made possible because of generous sponsorships from those organizations. We would also like you, if you could, please take the time to fill out a very short survey and evaluation for today's event. I have just dropped the link in the chat. By completing this survey, you will help us form new topics for future virtual sessions just like this, newsletter content. We really want to hear from you to learn what you want to know more about so we can provide you with that content. And finally, we don't have a date set for the April session yet, but we are working behind the scenes very quickly to get that date finalized with our speaker. And the topic will be managing fatigue and nausea to maintain quality of life. So thank you again to Lexi Budrag for her wonderful facilitating skills, Dr. Bardia for all of your knowledge and information and being so open with our audience. Thank you so much. And to all of you for attending, thank you. If you have any questions, please feel free to email us directly or visit our Metastatic Breast Cancer Impact Series webpage to learn more. Thank you all so much for joining us, and I hope you have a very good day.